Welcome back, everyone. We're going to continue on the series with discussing gynecologic emergencies. Gynecologic emergencies, with management of these pre-hospital, it's predominantly focused around mitigating life threats. We're going to ensure adequate breathing, oxygenation, and circulation, and support those accordingly with based on our level of certification status, our existing protocols, and what we can do within our scope of practice for these patients. It's important to understand that with any emergency and with any patient, you should respect the patient's modesty and try and protect that patient's modesty and provide emotional care to be a compassionate provider. But this can be particularly the case when we talk about genitourinary disorders, reproductive disorders, or obstetrical disorders and gynecological disorders. As far as management of gynecologic trauma, the female genital area is a highly vascular organ system, and there are a lot of large arteries and vessels, and that means that bleeding can be profuse. And exsanguinating vaginal hemorrhage must be treated as any exhausting hemorrhage would be and needs to be taken seriously and treated accordingly. One of the diseases we'll talk about is pelvic inflammatory disease. This is an infection of a woman's reproductive organs. Although PID is often a complication of a sexually transmitted disease, it can occur with other types of infections. The disease process is caused by an organism that typically enters the vagina and migrates into the uterine cavity. The infection can expand up to the fallopian tubes, and purulent fluid drips out of the tube and onto the ovary and the surrounding tissue. Peritonitis may develop, and pelvic abscesses can form. These patients typically present with pain starting during or after menstruation, and it's diffuse across both quadrants of the lower abdomen. Associated symptoms can accompany vaginal discharge, fever, chills, pain, or burning sensation upon urination. Additional risk factors include untreated sexually transmitted disease, frequent sex with multiple partners, douching, history of pelvic inflammatory disease, and recent abortion or childbirth or use of intrauterine devices. Pelvic inflammatory disease generally requires antibiotics, and our pre-hospital care for this patient is generally supportive in nature. A Bartholin abscess, there are two small ducts just inside the lower vagina that lead to the Bartholin glands. Within each of these glands, a cyst can form in one of the ducts and become blocked, causing that gland to swell. A Bartholin abscess can develop when these swollen glands become infected and have an accumulation of infectious material. A Bartholin cyst is usually small, and it can be seen externally upon assessment, or the patient may express that there's a lump or a bump near the Bartholin gland. A larger infected cyst can cause vulvar pain, a painful lump, and painful intercourse. If the cyst is infected or an abscess is present, then a physician will need to create a surgical incision and drain the infected gland through an IND procedure. Vaginitis is an inflammation of the vagina caused by an infection. It can spread upward into the cervix, uterus, fallopian tubes, and ovaries to cause pelvic inflammatory disease. Common symptoms of vaginitis include itching, irritation, discharge, odor, painful intercourse, and lower abdominal pain. Vaginal yeast infection is a type of vaginitis. It's typically caused by Candida albicans fungus. Normally, the acidic environment of the vagina will help keep yeast from growing, but yeast population can increase and result in an infection if the vagina becomes less acidic. Vulvovaginitis is inflammation of the external vulva. Patients should be evaluated by a physician, and symptoms include redness, pain, swelling, discharge, burning, and itching. If untreated, vaginitis can lead to infertility, preterm birth, endometritis, PID, and an increased risk for sexually transmitted diseases. Long-term treatment includes antibiotics, and pre-hospital management is supportive. Cystitis is caused by a bacteria that can ascend from the perineum through the genital tract into the urethral opening. The infection is isolated to the bladder, and patients often present with suprapubic pain, cloudy urine, urinary frequency, hematuria, and dysuria. If left untreated, cystitis can lead to polynephritis, and polynephritis is an infection of the kidneys. Treatment of cystitis and polynephritis include antibiotics and pain relief, and prehospital care is going to revolve around pain management and vital sign support care. Ovarian cyst is a fluid-filled sac on or within an ovary. They're common, developing in both ruptured and unruptured ovarian follicles. They're typically asymptomatic and can cause some pelvic discomfort, urinary retention, or urinary frequency or menstrual irregularities. The ovarian cyst can rupture spontaneously or after mild abdominal injury, intercourse, or exercise. If a rupture does occur, symptoms may be absent, all the way ranging to severe. Lower abdominal discomfort can occur and may radiate to the back. Ovarian torsion, similar to testicular torsion, is a twisting of the ovary so that its blood supply is interrupted. Must be considered if abdominal pain is severe and symptoms are progressive. It's more common in patients with ovarian cysts, and it's a surgical emergency that can lead to permanent damage of the ovary. Typically hallmarked by an acute onset of moderate to severe unilateral pain in the lower abdomen that increases over a period of hours. It's tender to palpation and often with a mass that's palpable on assessment. Prehospital treatment for ovarian torsion or ruptured cysts include recognition, transport to an emergency department, and symptom management. Endometritis is an inflammation or irritation of the endometrium. It's often associated with bacterial infections and more likely after a baby or having a miscarriage. Symptoms can include common infectious symptoms such as fever and chills, accompanied with vomiting, tachycardia, lower abdominal or pelvic pain, as well as foul-smelling discharge. Management providing reassurance and transport in a comfortable position, IV fluid and fluid volume resuscitation may be required. Endometriosis is the most common complaint. The most common complaint with endometriosis is pain. Other symptoms can include heavy or prolonged menstrual flow, extremely painful menstrual cramping, painful intercourse, sensations of rectal pressure or urgency, fatigue, and bleeding between periods or premenstrual spotting. Prehospital care is based on signs and symptoms, and pain management, pharmacologic pain management may be needed for these patients. If a patient reports severe pain, provide pain relief. Position the patient comfortably and use dressing or towels as needed. Uterine prolapse is a protrusion of part or all of the uterus outside of the vagina. It's classified by first, second, and third degree and revolves around the amount of the uterus that is protruding. Predisposing factors include genetics, obesity, weakening of pelvic support due to decrease in estrogen production, an increase in intra-abdominal pressure related to pregnancy or difficult childbirth. Patients often report pelvic heaviness or fullness, fatigue, low back pain, and symptoms are worsened by prolonged standing and relieved typically by lying down. With a uterine prolapse, the prehospital provider shouldn't return or replace any tissue. Cover with warm and moist dressings and transport the patient to the closest appropriate facility. Dysfunctional uterine bleeding is one type of vaginal bleeding, uterine bleeding that is abnormal in the amount of frequency or more than every 21 days. It's diagnosed after ruling out anatomic or systemic conditions such as medication therapy or diseases, and can occur when the hormonal events responsible for the balance of the menstrual cycle are interrupted. Risk factors for dysfunctional uterine bleeding include extreme weight loss or gain, over 40 years of age, high stress levels, polycystic ovary disease, long-term medication use, excessive exercise, or anatomic abnormalities such as uterine fibroids. You also may encounter traumatic vaginal bleeding. It's not uncommon after vigorous voluntary intercourse, although violent involuntary sexual activity should be considered. Other common causes include saddle-type injuries, pelvic fractures, a direct blow or pressure to the perineum, foreign bodies inserted into the vagina, or attempted abortions. Complications include severe bleeding, organ rupture, and hypovolemic shock, and you should treat the patients as you would with any other potential for shock. Ectopic pregnancies are another cause of vaginal bleeding, and it's when a fertilized oocyte is implanted somewhere other than the uterus. An ectopic pregnancy can be a life-threatening cause of vaginal bleeding in early pregnancies, and risk factors include previous surgical adhesions, ectopic pregnancies, pelvic inflammatory disease, tubal ligation, and intrauterine devices. A fertilized oocyte, when it's Ectopic and stuck in the fallopian tube, it will stretch the fallopian tube as it grows. 3 signs of implantation in the fallopian tube include abdominal pain, delayed menses, and abnormal bleeding or spotting 6 to 8 weeks after the last normal menstrual period. So it is important to understand the last menstruation or inquire about the last menstruation when you're assessing your female patients. Most patients do present with abdominal pain, and as the tube stretches, pain becomes colicky and then stabbing. With rupture, pain becomes excruciating in the lower abdomen, and referred pain is often common to the shoulder. For management of these patients, you should ensure adequate oxygenation and ventilation, and then support circulatory status as you would for any patient in a hypovolemic state. For EMT basic providers, this will be oxygenation, keeping the patient warm, and providing a position of comfort. For advanced level providers, you may consider things like IV fluid resuscitation. Anticipate vomiting with this, and you may need to treat proactively with Phenergan or Zofran. Keep the patient warm and monitor the patient's ECG if it's within your scope of practice, and transport to an appropriate facility. Notify the hospital of a suspected diagnosis, condition, and ETA, and recheck your vital signs frequently to ensure the patient isn't in a state of decompensation.